Good evening and welcome back if you've been watching the Cancer Awareness Summit here on blackdoctor.org. And welcome if you are just joining us. My name is Shamika Rhymes and I'm your host for this evening. Be sure to drop in the chat where you're watching from. And if you have any questions tonight, please put that in the chat as well and make sure you share this with your network. And if you haven't caught the other panels that we've had this evening, earlier we had pancreatic cancer awareness. And then the last one was just cervical cancer awareness. So make sure you check those out as well. So tonight during this panel, we are focusing on lung cancer, one of the leading causes of cancer-related deaths, yet it's a disease that's often misunderstood. Lung cancer affects thousands of people every single year, and it's especially important for our community to be aware of the risk factors, early symptoms, and life-saving screening options. So we're going to dive into the latest advancements in treatment, how smoking and environmental factors can play a role, and how you can advocate for your own health. So let me introduce you to our panelists tonight. Dr. Sandy Kotaya is a medical oncologist at Mercy Hospital. Hi, how are you?
I'm on mute. Hi, how are you guys?
Doing well. It's good to see you again. And Dr. Karen Reckamp from Cedars-Sinai, a thoracic oncologist and division director of medical oncology for the Women's Guild Lung Institute at Cedars-Sinai. Welcome.
Thanks so much, Shamika.
Well, let's start by explaining exactly what is lung cancer. And I know there's several types of lung cancer, if we could dive into that. Which one of you would love to start with it?
I'm happy to.
Okay. Go ahead.
So lung cancer is not just one cancer, but many types of cancers. I think that's the important thing. In 2024, we know a lot about the biology of lung cancer. And so lung cancer is not just one thing. When we think about lung cancer, there are two main types. One is called non-small cell lung cancer, which just under the microscope has larger cells, so they're not small, and small cell lung cancer, which have small cells under the microscope. And it's really that simple, just based on what it looked like. Small cell lung cancer tends to be more associated with smoking, almost always associated with smoking, and can be very responsive to chemotherapy, but also can be a little more difficult to treat. Fortunately, non-small cell lung cancer is the most common type of lung cancer, and that can be separated into many types of lung cancer based on the genetics and the potential to respond to specific targeted therapies or immunotherapy. So we look at specific genes that may be mutated that may cause the cancers to grow. And so in 2024, it's not just lung cancer, it's what type of lung cancer, and that's going to guide the treatments that a person might receive.
Thank you. Dr. Kotaya, did you want to add anything to that?
I mean, I just say to the patient, just think of cancer as a fruit, and then do you have an apple or an orange? Like, it does matter what type of lung cancer you grow in terms of treatments. And like Dr. Reckamp said, that, we do testing of the cancer cells up front now, and sometimes we give drugs up front before surgery, which we didn't used to do. We used to do surgery first for the earlier stages. But now, there's been some studies coming out that maybe we should try to give medication up front to make the surgery easier, to give you a better sense of who's going to do better over time. So things are shifting. And I think it's very important when you get diagnosed with lung cancer that you have a team of physicians taking care of you, including an interventional pulmonologist, medical oncologist, sometimes a radiation oncologist, the thoracic surgeon, and they're all sort of discussing the cases. But, some lung cancers grow slower. Some lung cancers grow much more quickly. Small cell lung cancer is generally considered an emergency type of diagnosis. We tend to try to get treatment started within days to weeks because it can grow within days to weeks. And, non-small cell lung cancer, depending on the type you have, can take months to years to grow. So, but we always try to stage the cancers first, and then we sort of go from there and then, try to figure out the best treatment plans.
Okay. What are some of the common symptoms of lung cancer, and are there any early warning signs that people should look out for? Because it sounds like with the different types, I know, Dr. Sandy, you said it really doesn't matter because, it's apple or orange, but for each kind, is there like specific symptoms that and signs that could be telling of which one it is or there's something wrong?
No, I think it does matter what kind you have, because not all of them respond to the same types of treatments, and not all of them are as treatable. So
Gotcha.
I didn't mean to come across saying it doesn't matter if it's an apple and orange. I just tell them there's cancer is like the overlying thing, but there are subtypes.
Gotcha.
So that's how I sort of describe it. But, you know, I mean, there's screening now for lung cancer. So, you know, if you have, I think it's like a 20-pack year history between the ages of 55 to 80. You know, we do tend to screen patients for lung cancer. Some people present asymptomatic and just being found on a scan. Mm-hmm. And then, you know, other people have cough that doesn't go away, pneumonias that don't clear. They cough up blood if they have a certain type of lung cancer that sort of more near the airways. Some people have bone pain because their cancer has already spread through the bone, and that's how they're presenting. So, you know, I always tell patients anything that's new or different that you haven't had before and that you don't have a good explanation for, you have to get it checked out. And if you have a persistent symptom and you've taken antibiotics and it's not getting better, then you should get a scan to make sure there's nothing deeper going on or nothing worse going on.
Okay. Dr. Reckamp?
Yeah, I think that Dr. Kotaya really mentioned the most important thing is that lung cancer screening catches lung cancers earlier and cures more people of their lung cancers. And that's been shown. And in the United States, we are really poor at screening those people who qualify for lung cancer screening. And so as she had mentioned, at this time, people who have smoked for 20 pack years, so when we calculate that, 1 pack a day for 20 years or a half a pack a day for 40 years would be a 20 pack year smoking history. If you have that and you've quit within the last 15 years, even if you're not smoking anymore, you should get lung cancer screening, and that could save your life. So that's the most important thing, because lung cancer is caught early, often before they have symptoms, are the most curable most of the time. And so the symptoms that are described have to do with your lungs most of the time. And that's, you know, coughing and trouble breathing and things like that. That's often when the cancer has grown large enough that it may not be curable. And so the lung cancer screening is the number one most important thing. And so if you're listening today, if you have a loved one who's smoked in the past, lung cancer screening can potentially save their life.
What exactly does that screening look like? Because I don't know if I've even ever heard of lung cancer screening.
So lung cancer screening means a low dose CT scan of your chest. And so it's a lower dose than standard CTs, and generally lower cost than standard CTs that should be paid for by insurance, but it is kind of low dose, low cost CT scan. So worrying about radiation exposure and things like that shouldn't be a major concern. And what they can do is find small nodules that may be in the lungs and maybe something that need to be looked at further. And again, if it is an early lung cancer, could be potentially cured with local therapy.
Okay, thank you. You know, we've talked a little bit about smoking playing a role in some lung cancers, but what other risk factors are there? Because I had a guest, I think it was a couple weeks ago, she mentioned her mother had lung cancer, but she had never smoked a day in her life. And she just had like some other health issues like her kidneys and something else. I forgot what it was, but she just mentioned, I remember that part about her mother never smoking and no one around her was smoking. So what are some other risk factors?
You know, there's some people just get cancer without a great explanation. Unfortunately, I did have a patient who had secondhand smoking exposure, and she got lung cancer from her husband's smoking. But, you know, like there are many times when patients get cancer and we don't have a good explanation. We have people who are, I mean, when I was a resident, one of my co-residents who was a year younger than me at 27 developed, you know, hip pain when he was running, and he had stage 4 lung cancer. And it ended up being something that had a targeted mutation. So he managed to live for another like 8 or 9 years with an EGFR mutation. But there's not always a rhyme or reason why people get exposed. I mean, some people can get exposed to chemicals that they inhale. You know, obviously asbestos can cause, you know, mesothelioma. So there are certain things that people can get exposed to in the environment. But for the most part, smoking to me is the number one risk factor. And it's really hard to get people to do smoking cessation even after they've gotten lung cancer. And I think it's very challenging. And it remains something that prevention is key. So, if we can prevent people from exposing themselves to carcinogens, it would help a lot.
Okay. Would you say that it's in food as well? Because I've heard people saying, oh, you shouldn't eat certain things off the grill because it could have carcinogens in it. I don't know if that has anything to do with it as well.
That's more related to gastric cancers
Okay.
and specific type of grilling. So those are GI type of things that because it hits the lining of your stomach.
Yeah.
But there are some radon has been shown to increase the risk of lung cancer, and there is some data to support particles in the air, and so pollution. And we don't know well enough about that, but it's definitely a concern. And then when we think about non-smoking lung cancers, there's a cohort of people who have non-smoking lung cancers. And I think we're really behind on knowing about what's inherited. So in breast cancer and even prostate and pancreatic cancer, we know about some inherited risks for cancers. And in lung cancer, because smoking has been so tied into lung cancer, I don't think we even started taking good histories on lung cancer. People would say, oh, my dad had lung cancer. Oh, but he smoked. Okay. So we kind of like that. We didn't even mark that down until we started understanding, again, the genetics of lung cancer and some of these specific types of lung cancer that are non-smoking types of lung cancer. Sometimes we see them in specific populations of people. The EGFR mutation happens a lot more frequently in Asian populations, and we don't know why that is, and in non-smokers. But so there are certain things that we don't understand. We haven't been great about genetics. It's just an emerging field in lung cancer. But we are starting to try and understand, especially people with family history of lung cancer, whether they may need screening, and that we don't have a place for people who haven't smoked to get screening. But at this moment in time, if you have lungs, you can get lung cancer, which is kind of a scary thing. And the stigma associated with lung cancer still has to do with the fact that it's so attached to smoking. If your family member who had lung cancer had been told a friend that they had lung cancer, the first thing they'd ask them is, did you smoke? And then that brings a stigma that the person didn't smoke, but it brings a stigma to themselves saying, I caused this, or that person thinks I caused this to myself. So we've got a long way to go with lung cancer to help people that, as Dr. Kotai mentioned, sometimes we just don't understand, and we don't have a great reason, and people live very well, healthy lives, and they still can get lung cancer. And so we have to get rid of some of that stigma and do better with that.
Thank you. Which I guess kind of also answered my next question, which was if there's a specific age and risk level that individuals should consider getting screened, because, if they don't have a family history or they don't smoke, it's kind of, I guess, maybe they could or maybe they can't yet. I don't know.
There isn't specific screening for people who haven't smoked at this moment in time, but for people who have smoked, it's 50 years old. 50. So, and so for non-smokers, it's a little more challenging, and again, often waiting till symptoms makes it a little more difficult to treat.
Okay, thank you. Can any lifestyle changes make a significant difference in preventing lung cancer or improving outcomes for those that are at a high risk of developing it?
That's a tough question. I don't really think that there's any, the cancer guidelines are very broad and vague in terms of diet and lifestyle things that people can do. They say to try to eat plant-based, avoid processed stuff, especially processed meat, exercise 2.5 hours a week where you get your heart rate up, like moderate intensity stuff. And they, want you to avoid, of course, smoking and drinking, and wear sunblock to avoid melanoma, and keep your BMI below 25, because, the healthier weight, you can avoid, chronic inflammation, like damage and things like that. And of course, some people have argued that if you sleep well, your immune system is boosting overnight. And if you have chronic insomnia, that can cause illnesses and a depressed immune system and allow cancers to develop. But I don't think there's a magical thing that any of us can really, even with all those things, it's like a 20 to 40% reduction in getting cancer. So it's not like Even if you're perfect with your diet and exercise, you're 100% going to avoid cancer. But I think you do your best to try to eat clean and to try to avoid chemicals as much as you can. I mean, I know you guys are going to make fun of me. I saw a TikTok video on Facebook. I don't belong to TikTok. I'm a little too old for that. But
you and me both.
But it was like somebody who was living in China, and like she was showing the outside of her window, and it was like filled with pollution that day, in the city. So, I think, avoiding living in highly polluted cities, which is not always possible for everybody, would probably help also prevent the lungs from getting damaged. But I don't know if Dr. Reckkamp has probably better ideas than me, but that's sort of all I have, in terms of prevention.
Okay. Those are good ones.
Yeah, I mean, lung cancer prevention, the best thing you can do, obviously, is not smoke, not ever smoke. And if you do smoke, to stop. That's number one. And number two. But outside of that, there haven't been a lot of studies to show that one thing or another is going to prevent lung cancer. And there have been vitamins and things like that we've tried to look into, but we really haven't found any magic to prevent lung cancer per se. Now that we have, for breast cancer, there are some preventative measures that people can do. Obviously, you're not going to cut out part of your lung, but now that we know something about the genetics of lung cancer, and if we learn a little bit more about family history and that risk, there may be some oral therapies that may end up being something that can help to prevent lung cancer in somebody with a high risk, maybe with a family history. We're not quite there yet, but that may be somewhere where we're going over the next decade or so. So I think we're learning more. We know more about the biology of lung cancer and the types of genes that can cause lung cancers to grow, which can help us to, again, get at helping people become cured from their lung cancer or potentially not develop it at all.
Okay. Well, what are the current standard treatment options for lung cancer, and how do they differ based on the cancer type and stage?
Wow, that's like
that's an enormous question.
By the way, I want to say that just like colon cancers and breast cancers are getting diagnosed earlier, there are patients who are younger who are getting lung cancer, and some people think that I have to smoke long enough to get damaged to get cancer. That's not always true. There are patients in their 30s and 40s who get lung cancer from smoking. So it's important the sooner if you don't pick up that bad habit, you're going to be better off, and some people start smoking when they're teenagers. I think that's happening less often, but that's one of those things. But I will say that in the broadcast, when I meet somebody with lung cancer, I sort of say to them, in my armamentum of things that I can give as a medical oncologist, there's chemotherapy, which, will kill whatever's growing fast. It's not specifically targeted to your cancer, but, things that are growing faster, it can get the faster it grows, the more it can get affected by chemotherapy. The response rates depend. If you have a small cell lung cancer, the response rates can be as high as 80%. If you have a non-small cell, it can be as low as 30 to 40% with chemotherapy by itself. And then you have immunotherapy, where you try to get your own immune system to kill your cancer cells. And that's been, I think, life-changing for some patients. I've seen some patients get cured with immunotherapy, even with advanced lung cancer, but not everybody responds to immunotherapy. We tend to look at markers like PD-L1, which is a protein that gets expressed by the cancer cell that allows it to hide from the immune system, to try to guide maybe who can just get immunotherapy alone or just get immunotherapy with chemo, although we tend to do immunotherapy with chemotherapy together and for the most part. But, and then there's patients who have a mutation in the cancer cell that's driving the growth that we can try to target with usually a pill. And that's about half of the patients. So, if you're talking about in the big scheme of things, are you a candidate for surgery because you have stage 1 and 2 cancer, maybe stage 3, some stage 3s? Do you need to get radiation, which is usually people who are inoperable because of medical conditions, or who have more advanced lung cancer, like it's a stage 3? Or are you looking at drugs? And, drugs usually, we're looking at some maybe bigger stage 1 cancers, but definitely stage 2 to stage 4. It usually involves medical oncology in some way. So, that's kind of like how I explain it to the patients. But I don't know if Dr. Reckkamp wants to chime in and save me from my diatribe, but.
No, I think that it's you've asked a big question, because it depends on stage and it depends on biology. And so, the very early stages, smallest tumors, can be treated with surgery. Sometimes local radiation or ablation can be enough for the smallest tumors.
Mhm.
Those are not the most common. Unfortunately, still more than half of people will present with either a locally advanced or metastatic lung cancer. So again, back to the reason why we need to do more screening. And if it is more advanced, then we are generally recommending that patients have what we call a multidisciplinary team looking at their case, because that time before surgery, we can have more patients be cured potentially if we give them the chemotherapy and immunotherapy. But for certain genetic changes that occur, we don't want to give immunotherapy. We want to give targeted therapy. And so we need our medical oncologists, our surgeons, our radiation oncologists, our pathologists, and radiologists all in the room to discuss how best to treat these patients and give them the best chance at long-term survival. And as has been mentioned, we do see long-term survival even in people who have metastatic disease, which again, a decade ago, we wouldn't have been able to discuss that. But we're seeing longer and longer survival where people are actually living with their lung cancer, even on treatment, even with advanced disease. And so I think the key take homes are that chemotherapy still is something we use for lung cancer. And most people at some point will get chemotherapy. So it's not gone away. Immunotherapy by itself can cure a few people with lung cancer and can be an option, but often we use it together with chemotherapy. And then the targeted therapies have changed drastically how we treat lung cancer. So you shouldn't start treatment for lung cancer without knowing what the genetics of the lung cancer are. And I think, again, that's an important tool to know that you should ask your doctor, what are the genes in my lung cancer? It may not be any that are relevant for a new therapy, but you should know that going in. And too often we decide that people are not going to be tested for one reason or another. There may not be enough tissue, there may not be, but it really would be, it really is not in a person's best interest to start treatment for lung cancer in 2024 without having genetic testing of the tumor. And so I think that's a really important thing. And there are about 9 different alterations that we can treat with targeted therapies now for lung cancer.
Thank you for sharing that, because I did not know that. So that is definitely an important thing to highlight. Would you say clinical trials are also helpful to contributing to advancing lung cancer treatment? And what should patients know about enrolling in them? Because I know sometimes patients can be a little leery of, should I do a clinical trial or should I not? What are your thoughts on that?
So I think the most important thing is the advances that we've been talking about today all became possible because of clinical trials. We would not have these treatments today without clinical trials. So clinical trials are important, and it can be scary to think about something new being tested on you. There are different types of clinical trials. So generally, when you talk about a phase 1 trial, we're testing out either a drug or a combination. We're as interested in how many side effects it will have as in how it will help the cancer. But often in a phase 1 trial, everybody gets the drug, so there's no placebo. So you know you're getting the new drug. But again, we're looking often at side effects, but some of those phase 1 trials move on to help people and be that treatment that will move on. And a phase 2 trial looks a little bit more at how well it's helping a tumor shrink. And then a phase 3 trial is often a comparison trial. And so in that trial, nobody's going to get a placebo without treatment, but there may be a placebo with a standard treatment versus that new treatment. And you have to understand that not all new treatments work. And so we have to do those phase 3 trials to understand, as sometimes that new treatment is not as good as the standard treatment. Often people go into a trial saying, I want only the new treatment. But that's the reason we do the trial is because we don't know. But they are what have brought us to these milestone changes in how we treat lung cancer. When I started about 20 years ago, people didn't live much more than a year. Even people with earlier stage lung cancers. Now people are living many years. And the only reason that is because of the clinical trials that have been done with these new agents. So it is important. And it's always good. people sometimes think, oh, I shouldn't do a clinical trial until I've run out of all the other options. But that's not always true. There are sometimes clinical trials for kind of any phase of the part of treatment that you have. And you should always be discussing it and finding out when the right time for you might be.
I'm just going to piggyback on Dr. Reckcamp's comments that not only living a few more years, but some people are being cured because of the research that was done, even with stage 4 cancer. So, you know, that was not possible. I mean, I've been only in practice for about 14 years, but, you know, like when I started, there was no such thing as curing stage 4 lung cancer. So, and then the other thing is, I mean, I myself am opening up 3 new lung cancer trials in the next couple of weeks because, and not just people who've like, oh, I've seen a lot of treatment and now I'm at my ends, at the end of my treatment. So therefore, what should I do? But because even with the best treatment we have and as much success as we've had with some patients, other patients don't respond and they don't get the benefit and they're still going to succumb to their cancer. So how can we improve on what we have? Can we make immunotherapy work better? Can we make different combinations of things? Can we get more effective targeted drugs? I mean, even when you get on a targeted drug, you know, it doesn't usually cure you. It can buy you some time, and some people can buy them many years, but it doesn't usually cure them. So, you know, we're doing better, and lung cancer is becoming more of a chronic illness for a lot of patients. But I think that if we can cure more people, then, you know, then why not? And that involves some trust that we're not experimenting for the sake of experimenting. We're experimenting because we're trying to improve outcomes. And I live in Baltimore, where the Henrietta Lacks building just went up at Hopkins as a way to try to make up for the things that happened in the past and trying to build trust with the Black community about the fact that we are trying to help them, because we do want more Black patients on trials, because we don't want everything to be skewed towards Caucasian populations, so that we can know, because biology is different, but also the environment the cancer grows in can be different. And different races don't always respond the same to the same type of treatment. So it's important to do the research to figure these things out.
Absolutely.
And I'll just make one more comment as it just to add to that unfortunately, Black patients have been too underrepresented in clinical trials. And because of that, as we've talked a lot today about the biology of lung cancer and how different cancers act differently, we don't know specifically how most of these approved agents are going to be specifically in somebody with African ancestry or somebody who is Black. So we need more people involved in clinical research. And again, we need to develop that trust and to bring people on. One of the trials that we're doing that's being run across the whole United States through our national clinical trials network that's run by the NCI, the National Cancer Institute, is a trial that is pragmatic in design. And so it reduces the burden of a lot of extra tests that we often do. So clinical trials often require extra visits, extra tests, and sometimes people just can't do that in their day in and day out life. You know, they're dealing with cancer, much less they're trying to hold on to a job. They're trying to hold on to taking care of their kids, whatever they've got. We all have lives anyway. And so sometimes it's a little too much. So we're trying to find ways of making more pragmatic trials that allow people in that would be not so different than their standard treatment and not ask them to do so much different. And I will tell you that in this trial, we have really reached out. We're across the whole United States in multiple communities and in community sites. And we have now have about, depending on the day, 13 to 14% are Black patients. So kind of matching the population, which has been unheard of in most clinical trials that we've done thus far. So I think doing trials differently, it's not that people don't want to do it. It's that we have to make trials that work with people's lifestyles in addition to us asking a question that we think is relevant.
Thank you. What advice do you have for patients to advocate for themselves after receiving a lung cancer diagnosis? Because I'm sure it's as we've discussed in other panels this evening, once someone hears that C word, it's kind of shocking, and they just kind of go into this frantic, like, what do I do next? What do I do? What should I be asking? Who should I be asking? All those things.
So I think that, you know, the first thing to do is having a trusted friend, family member, somebody to be able to just, shed a few tears and talk about your anxieties. If you don't have that, reaching out, trying to get an appointment with a cancer specialist, because often our groups will have social workers and other groups that you can reach out to. Googling everything on cancer is not generally the most helpful first thing you can do. People want information, but there's just a lot of information out there. And as we talked about, there's so many specific types of lung cancer. Just looking up lung cancer is, I think, usually more frightening than it needs to be without some context. So getting connected with a clinic and a physician, getting connected with with a trusted family or friend, and starting the journey, and knowing that it's a journey. And what we can do for most cancers these days is very different than what you might have fears about, what you heard about from years ago from some family member. It's always changing. Even if it was 2 years ago, it's probably different now, and probably somewhat better. And so getting the real information, being an advocate for yourself, or finding someone who can be an advocate for you, because our medical system is not easy to navigate. It really is not patient friendly. And so advocating for yourself, asking questions, and trusting your gut in some way, that if this doesn't feel right for you, to ask the questions, get those questions answered, and find somebody you can work with and trust.
Mm-hmm.
I was going to say, we hate telling people they have cancer just as much as they hate having to hear it. It's not like you get used to it. Like, the longer you do it, you can't get immune to that, because, you're changing somebody's life by saying that word. And I think Dr. Camp is right. Like, if you're meeting with the oncologist, if the pulmonologist has done a biopsy on you, they might or might not have explained to you about the biopsy, but it was over the phone, and you got a PET scan, and now you're showing up to the oncologist, you're not, like, waiting for them to explain everything to you. The basics are, you have, like she said, you have to have somebody be your second set of ears, because people who show up alone, they usually forget a lot of what we tell them. I usually try to write everything out. What is your stage? What are your treatment options? And what is the best step going forward? And I give people a checklist. These are the things that you need to get done. You need to get this scan done. You need to get, that blood work done. You need to get, we need to get this testing, and this is going to take this long. So I try to manage expectations, because I think that helps with the anxiety piece to some degree. But you're right. Like, I have a nurse navigator. She's going to help you figure out which appointment to get to. And if you get lost, just call her. She's going to make sure you get back on track. If you need medications, we're going to have somebody work on authorization for you, so you don't have to worry about fighting the insurance company to get those things done. I think the more you can take off the patient's plate and just explain to them, then they tend to, like, okay, I have a plan. When people have a plan, they get less anxious. When they don't have a plan, they feel like they're floating around without anything, and they're imagining their cancer cells growing by the day, which is not usually the case for most patients. So I think it's very important for patients to look at, even if there's some patient-friendly websites, these are the questions you should be asking your oncologist. I get a lot of questions about, what should I be doing? What can I do in the meantime? And I always tell them, eat, stay strong, stay active, because, the more active you are, the better it's going to be. The more active you are, the less fatigue you're going to have, and that's all you can do while you're waiting for us to figure some things out, so we can come up with a finalized plan. Or no matter what, this is your plan, but this is what I want you to do, and give the patient some tasks. They have bills. They're not just their cancer. There's things that are going on that might be barriers. We try to address all those things. And I think having, a mental health therapist is super important. We don't have as good of a mental health program as I would like. And it's really hard nowadays, especially post-pandemic, to find people to help with that piece of things. But I think treating the patient as a whole and having them be able to ask questions about, where can I get support? What do I need to know? Some people will ask me, is there something I haven't asked you? And if they haven't, I'll tell them. Mm-hmm. But, it's very hard. But I think if people ask questions, we want to help people with cancer. That's why we went into oncology. We're not there to sort of tell you that there's no hope. And we always try. And if we really think that we're going to harm you with treatment, then we tell you, and we try to be upfront about it, so we can set goals and expectations. But, hopefully the most important thing is connecting to your team and feeling like you can talk to them and ask them questions and get, clear answers, and, and get compassion, when you need it,
Thank you. And I know Dr. Reckamp has to go. Thank you so much for joining us and sharing your insights. It's been great.
Thank you so much. Take care. It's been wonderful. Bye.
All right, Dr. Kataya, you're mine now. Oh, you're on mute. I can't hear you. Sorry. Oh, hold on. It's still.
Sorry, it's
There
just
you
you and
go.
me now.
Just, yeah. Only a couple more questions, though.
That's fine.
Um, so, how can patients ensure that they're fully informed? I know they've got to ask the questions, but when do you suggest that they get a second opinion? Is it really just if they? I know Dr. Reckamp mentioned that if they don't feel comfortable or feel like their questions are being answered, when should they feel comfortable, or maybe not feel comfortable? That's not the right word I'm looking for, but at what point should they say, let me just get a second opinion, or should they get in a second opinion?
I mean,
Or
why not? It's
yeah,
cancer, right? We're not
yeah,
talking about high blood pressure, and even that high blood pressure and diabetes, people can get a second opinion for that too.
yeah.
I mean, we're living in an age now where people are having can have access to resources and to make sure that they feel comfortable. I mean, most of my patients don't get second opinions, but it's not because I discourage them. Because if
Mhm,
their plan is straightforward, we go over the cancer guidelines, fine. But I would never discourage a patient from getting a second opinion because at the end of the day, you have to make sure that the plan that is being set out is definitely something that somebody else should tell you. And most of the time, for lung cancer, there can be some variation. There's a little bit of an art to medicine. Some
mhm,
people might want to get drugs first. Some people might want to do surgery first. And the explanation, the rationale has to make sense. But, for the most part, the plan shouldn't be varying so much that what you hear from one oncologist is completely different than what you hear from another oncologist.
right.
And there are people who have rare tumors and who have like atypical presentations. And I will tell them, please go see Dr. So and so at this facility because I want to make sure that what I'm thinking and what I'm seeing is going to be the same thing as what they're thinking and they're seeing. So I will myself initiate second opinions if I feel like somebody's not quite presenting or behaving the way that I think, and I need to make
Mhm,
sure that I'm on track. And there's no shame in that. I mean, we should be all exchanging information, so all for the better of the patients. But I think anytime you as a patient, like, is this the right thing? Do I really want to go through this? Does this sound right to me? Like, you can go ahead and get a second opinion. And you can even ask your oncologist, like, I want to go get a second opinion. Do you recommend somebody? Or you can ask your primary care if you have a long relationship with them. Hey, I want to see somebody else to make sure that they're saying the same thing. Can you send me to another institution? It's totally fine. There should be no ego attached. So at the end of the day, if the patients if you and the patient have form a bond and you trust each other, there's that's the best relationship. You don't want somebody to stay with you as a
mhm,
physician who doesn't quite get you or like
yeah.
doesn't quite like your personality or doesn't like your treatment plan. You want them to feel comfortable that they're in a therapeutic relationship with you, that what you're
Mhm.
saying makes sense to them and they feel comfortable going through with that treatment plan.
Okay. Well, what questions should patients be asking their doctors to better understand their diagnosis and make informed decisions about their care?
I think the questions are the basic stuff, which is what is the stage of my cancer? What type of
Mhm,
lung cancer do I have? What is my treatment plan? What are the things that I should be doing to help myself? Can I have access to, the nutritionist or the social worker or the navigator? What is the worst case scenario? What is the best case scenario? Are there any long-term things that I should be thinking about? Are there things that I should be, planning or thinking about that I'm not asking you about? Like things like that. Like,
mhm,
where, I'm more of a planner. I don't like to just fly by the seat of my pants. I want to
mhm,
know exactly what I'm tackling and what I'm looking at. Big, like, long term, short term, what are the risks I'm going to get this toxicity? What are the things that I can do to really maximize my outcome? Kind of things like that. I think everything is open to questioning, like, and if you feel like there's something that will not work for you because of whatever reason, because your mom's gone through it and you don't want to go through it, or like you had a bad experience with something, these are things that should be talked about. And
mhm,
either we try to talk things out and we end up doing things in a way that's not going to harm you, but you're still going to have a good outcome. But I always try to be open-minded about people's fears because people don't just come to cancer treatments with blank slates. Sometimes they've had people go through it before in their life, and there are certain things that they will not go through or that
yeah.
they don't want to go through, and that you have to kind of meet them where they're at and respect that.
Mhm. Well, is there anything else? We covered a lot today. Is there anything else that maybe we didn't cover that you want to mention to people watching about lung cancer?
No, I think, it is very tempting for people to blame themselves when something
Mhm.
happens. And I'm not going to lie and say that smoking didn't help contribute to lung cancer
Yeah.
or that alcohol doesn't contribute to cancer. But at the end of the day, it's not a helpful thing to be angry and questioning yourself and thinking to myself, what should I have done differently? It must have been that soda that I drank. It must have
Mhm.
been that Skittles that I ate. No, no. Sometimes these things happen and to other people smoke and they don't always get lung cancer, but it's much more helpful to say to yourself, this is what's going on right now. I need to just put aside the blame because it's not helping me in any way and it doesn't serve me. And I'm going to try to figure out what I'm going to do to get myself back on track and get myself healthy again. And there's a tendency to be like, hey, can I do this supplement, that supplement, all these supplements, whatever? Well, I mean, gosh, if I could just go into a business where I could just sprinkle some vitamin E and do something very benign and take care of cancers, I think I
Mhm.
would be the most popular oncologist in the entire
Yeah.
world. But at the end of the day, it's never that simple. It's never that simple that if you eat the right things or you do the right things, that you're not, or if you starve your body of sugar,
Mhm.
because most lung cancers light up on PET scans, and that's because they take up sugar faster than your normal cells. And people have a tendency to think, well, if I deprive my body of sugar, the cancer is not going to grow. That's not the case. It's not that simple. I mean, people
Mhm.
have tried keto diets, they've tried all kinds of things, and it doesn't stop the growth of the cancer cells. So I usually have my nutritionist explain to them, you have to eat a balance of protein and carbs, complex carbs, and fat to try to get the right nutrition in and
Mhm.
not deprive yourself of any particular nutrient. If somebody wants to take some complex, plant-based, vitamin and things like that, a lot of the things are not really regulated by the FDA. So, and sometimes,
Right.
believe it or not, there can be drug interactions with the things that you're taking, whether it's a pill that we're giving you or whether it's, an infusion that we're giving you. There can be drug interactions because most things that you're taking as chemicals, even if it's a natural ingredient, is cleared by your kidney or your liver. And if there's a drug interaction, it could cause a complication. So always talk to your oncologist and say, is this safe for me to take? Is there data that supports it? And we try to do data-driven things. I mean, there's some data about eating mushrooms and decreasing your risk of breast cancer.
Mhm.
So it's not like everything is like ridiculous. There are some things that have validity to them, but I would encourage people not to spend a ton of money buying supplements and or buying things from naturalists that have no clinical trial data where we know that there's a survival benefit to doing it. I think the most important thing is to keep yourself active and eat as cleanly as you can. And sometimes when you're going through things like chemo and things taste crappy, can I say that on live? When things taste horribly, you're not going to want to be like, well, I am just not going to eat that ice cream because it's going to feed my cancer, and then you're going to lose weight and get weaker. No, you eat whatever you have to do to eat to get through the
Mhm.
treatment if the treatment's trying to beat up your taste buds. And then when you get through and you get into remission, your cancer's doing better, then you can go back to like, I'm going to eat the way I want to eat to stay healthy. So it's
Mhm.
very important to remember that there's not one thing, even the best chemos that we have, even the best immunotherapy, even the best targeted drugs we have, do not have 100% cure rate. Nothing is ever 100%. There's never any guarantees with cancer. You hope for the best. You hope for the best outcome. You try to give patients as much support as possible, but you also understand that there are people who are not going to do as well as you want. And there are people who are going to do better than you think, and you have to deal with all of it. But try not to say like that there's something that I did that brought this on, and that's the reason why I have this. That's not true. I mean, it's just not true. And even if you smoke, there's no point beating yourself up. The best thing you can do, by the way, and studies have shown this, is once you get diagnosed with lung cancer, if you stop smoking, you actually have a better outcome and you have better survival, even if you stop the day you get diagnosed. So it is important for your survival, not just for the sake of not getting new cancer, for you to stop smoking when we're giving you cancer treatment. So those are the things that I kind of want to explain to people about, lung cancer and just in general.
Thank you so much, because this has been a great conversation. Um, yeah, this has been great. I did have one quick question about the smoking. It wasn't in our original questions, but Does it matter if it's like whether or not you're, I'm sure it does matter. Let me rephrase. Are there any studies about those that are, what do they call it? Vaping versus cigarettes, or those electronic cigarettes, which is probably
I think
vaping. I don't know the
anything that you
difference.
inhale into your lungs can damage your lungs.
Okay.
Even when people
Okay.
want to smoke marijuana, I'm like, no, why? Just go eat your gummies. Because I just don't
Yeah.
want them to inhale things into their lungs because I don't know what's in there.
Mhm.
I mean, most things that you inhale into your lungs, unless they're like, steroid inhalers to help your
Yeah.
asthma, like I don't know what you're inhaling and I don't know what they're mixing in there. So it's better for you to keep things as pure as possible and not try to inhale things into your lungs if you can get it some other way, whether it's through the tongue, like eating a gummy, putting a patch on. Those are things that are better than just try to inhale stuff in your lungs, I think.
Okay. I did see someone with a quick question about, they joined late, but they wanted to know, because they've had people with lung cancer get diagnosed in stage 4 that only lived a month after diagnosis. They were saying, when should someone check?
I mean, you're talking probably about like someone with small cell. Those are the
Mhm.
patients, if you don't get them on and if you don't get them treated, they will succumb very quickly. There are a few patients who like let it go, let it go, let it go till they're so weak they're like crawling to the hospital. So as soon as you feel off, you're better off coming to the hospital. But there are cancers that grow so fast and so aggressively, and thank God not the majority of them. It's very rare, and especially now that people are smoking less, small cells becoming less common, where it grows within days to weeks. And if you don't get treatment right away, you're going to be in trouble right away. But that's
Mhm.
not the norm.
Okay. All right. I think that was the only question I saw that popped up, and I wanted to make sure we answered that one. Thank you, Dr. Kataya, for coming
Yeah,
back and joining us.
sure.
I hope to see you again soon. This has been a great conversation. For everyone else, make sure you head over to blackdoctor.org, because there's plenty of articles over there on lung cancer and other various cancers. But stay tuned, because the Cancer Awareness Summit is continuing. Coming up next is the breast cancer awareness panel. So you don't want to miss that. And make sure you share that with your network. And I will see you guys soon. Thank you again, Dr. Kataya.
Thanks for inviting me. Bye.
Bye.